Welcome back to another episode of the Braun Performance Rehab Podcast. Joining me today is Dr. James Dreese, Dr. Kevin Kaplan, and Dr. Patrick Kane. The four of us are going to be diving into ACL surgical considerations, including extra-articular ligament procedures, graft choice, tourniquet times, use of functional braces, and so much more. We cover a lot of ground in this episode today, and I really appreciate having multiple surgeons' perspectives on the same issue at the same time. I really appreciate their time and all the value that they were able to bring in this episode today. Episodes like this are made possible by our sponsors, ISOFIT and Oro Muscles. ISOFIT is my go-to choice for all things isometric strength training, and Oro Muscles has been my go-to choice for a better in-depth look under the hood, so to speak, and understanding how someone is producing force and what muscles they're using. Personally, I feel that the combination of the ISOFIT and the Oro go hand in hand and is unrivaled in clinical practice. For more on ISOFIT and Oro, you can check the description below. I also highly recommend you subscribe to the podcast if you haven't yet, as I have a lot of additional content about the ACL coming up very soon, and I know you're going to love it and learn a lot. Enjoy. Dr. Dreese, Dr. Kane, Dr. Kaplan, welcome to the podcast. I'm super excited to work with the three of you today. Thank you so much for being here. For people who maybe aren't familiar with the three of you and maybe they're just unfamiliar with your practices that way, would you mind filling them in a little bit about who you are and all the amazing things that you do on the day-to-day?
Thanks, Dan. Pleasure to join you again. My name is Jamie Dreese. I'm a sports medicine orthopedist. I practice at MedStar Health in Baltimore primarily, and I serve as the co-director for our sports medicine fellowship here in Baltimore within the MedStar system.
Yeah, thanks, Dan. I'm Patrick. I'm a private practice orthopedic sports medicine surgeon. I did my residency at Jefferson and Rothman, and then did my fellowship out in Stedman in Vail, Colorado. And in your backyard, Dan, I practice in a coastal community here in Delaware, Lewis, Delaware.
I'm Dr. Kevin Kaplan. I'm a sports medicine specialist in Jacksonville, Florida. Actually born and raised here in Jacksonville, and did my training at NYU Hospital for Joint Diseases. And then went out to the Curl and Job Orthopedic Clinic for my fellowship, and came back. I've been the head team physician here with the Jaguars, now going on my 12th year with the team.
You guys have such a wealth of knowledge and expertise as it relates to, complex sports injuries. And in particular, I feel like anytime we say sports injury, people immediately jump to the ACL. Obviously, it's an issue that impacts tens of thousands, if not hundreds of thousands of individuals every single year. And it can be one of the most challenging and debilitating injuries that an athlete faces that way. And obviously, in my opinion, the right surgeon and the right surgical approach for the right patient can make all of the difference in the world for this kind of injury that way. For people who maybe aren't familiar with the ACL injury that way, or just based on the thousands of cases that you three have collectively seen, has there been any kind of common mechanisms that you see, any kind of common other structures injured, I guess I'll ask, or any unique cases that have presented themselves to you as it relates to the ACL injury that way?
I think ACLs, we've all changed, at least in the way we've learned ACLs in the past. I know the way I do my ACL reconstructions now is different than I learned at NYU, which was different than I learned at Curl and Job. And I think we're all striving to recreate the anatomy of what was torn. In addition, I think as we've gotten better at recognizing instability, we've come up with newer techniques, whether it's a Lemaire procedure, which is something that deals with patients that may have a little bit of extra laxity or looseness. I certainly think that technology and our understanding about instability has certainly improved tremendously from the time I started to residency until now. And I think that gives us better outcomes and a lower chance of having recurrence, because all these athletes are going back to doing what for it in the first place. And we're just trying to do our best job in preventing that from recurring.
I would echo Kevin's comments there. I think we'll probably all have similar comments, but I do think that there has been a significant evolution in our understanding of these injuries. Not so much what causes the injuries, because many of these are non-contact injuries. It's an internal rotation force on the femur with a relative external rotation of the tibia, valgus force on the knee. So that part of it's pretty similar. The contact injuries, I think, are a different variety and a different injury pattern sometimes. But I do think that our understanding of these injuries, as well as the concomitant injuries present with it, has made us think differently about the best solution for the problem in the sense of, I think historically we've been pretty good at controlling sagittal plane stability front to back, but we have not so much understood the rotational instability that, as Kevin alluded to, the Lemaire procedure and some other lateral sided procedures have been able to address more effectively. I'm sure we'll get into that more tonight. But I think that probably has been the biggest evolutionary change in our understanding of ACL injuries and the most effective treatment that we can offer our patients today.
We alluded to it a little bit, the concomitant injuries that I think maybe were missed in the past, like lateral meniscal root tears and ramp lesions that I think we're also getting better at recognizing. And I think help when we try to fix them in the setting of ACLs too, to reduce our recurrence risk of graft failure. I'm trying to treat the whole knee, not just the ACL in isolation.
Just kind of running it back, Dr. Kane, you just brought up the presence of the lateral meniscus root tear. And I remember you mentioning before that it's one of those things that it often sees us, but maybe we don't see it, in the sense that it's a lot more common than we think. I think you mentioned 1 in 7 or 1 in 8 was the statistic of ACL tears also present with a lateral meniscus root tear. So I think definitely echo your point on the importance of identifying that and also ensuring we do our due diligence to correct that. I remember you also mentioned about the importance of drilling a root tunnel separate from the graft tunnel, which you all understand way better than I ever will, but just understanding that we have to identify things and we have to address them correctly. And Dr. Kaplan and Dr. Dreese, as you both mentioned that way as well, the procedures on the outside of the knee, for lack of a better way to put it, to add additional rotational stability are absolutely essential. I remember recently, Dr. Dreese, you called that one of the biggest evolutions in the ACL rehab or ACL surgical world in your career. And I think the additional rotational stability that these procedures can add can really make or break someone's success. I certainly see a huge difference in the return to sport process for those that have that procedure versus those that don't have some type of extra-articular stabilization procedure that way. Walk me through kind of on your end that way, what goes into identifying some of these different other structural anomalies in the in the knee that could be injured that way, what you all kind of do from an approach standpoint there, and also what kind of leads you to decide, when do we choose one graft over the other? When do we choose to add extra articular stabilization to the knee versus when we choose not to? Or are we at the point now where we're just adding extra articular stabilization to all of the patients that we see that way?
Take that one on first. I mean, a couple of things. I mean, I think in terms of the changes, you kind of alluded to the changes over time in the surgical approach to ACL problems. I do think that there have been significant improvements, and I've been in practice for 20 years, and I think back to the way in which reconstruction was performed in the early 2000s via transtibial approach and the conversion to an antramedial portal or an over-the-top independent drilling of the femoral tunnel, I think really had significant benefits in terms of trying to reproduce the footprint. The better understanding of the anatomy of the ACL, I think, came a long way. I personally think that these lateral ligamentous augmentation procedures of different varieties have changed the success following ACL surgery more than anything I've seen in my career. I mean, in my own personal practice and examining my own patients and better understanding why so many of these patients after conventional ACL reconstruction historically would go on to tear their medial meniscus or have further injury to their ACL graft makes perfect sense to me in the sense that rotationally they were not stable, which put them at much more risk. So in my own experience, I think the changes that we've seen with these lateral procedures has really had an exponential benefit to our patients from that standpoint. But in terms of the evaluation of the patients, I think we know now that there are a number of radiographic findings that we historically didn't really understand the significance of them, that now we do much more so. That the recognition of lateral meniscal root tears continues to be a challenge, but I think we've gotten a lot better at it. The medial sided injuries are much easier to pick up. The chondral injuries, I think we pay more attention to, but I also believe that meniscal preservation has gotten its due attention, and that clearly we understand that preserving the meniscus is what we want to try to do in those situations. So I think that, along with the evidence of these lateral ligamentous injuries, the injuries to the anterolateral ligament complex and the other lateral ligamentous structures based on bone bruise patterns and other factors, is helpful in terms of planning for how to correct the injury itself. But I do feel like we've made some significant gains in our understanding of the injury.
And I'll add, in my practice, obviously exponentially higher rates of doing this type of extra-articular reconstruction and doing a Lemaire. But, I've reserved it, thus far. Obviously, anytime I'm referred to revision, I'll do an extra-articular augmentation, a Lemaire. I think, when I get a patient in the operating room and they have a grossly positive pivot shift, and I think that's what we're talking about. Obviously, that extra laxity, I will do one as well. In patients that have a lot of laxity, whether it's recurvatum that I'm worried about are going to potentially tear their ACL again, I'll do that as well. But I think my indications have kind of increased over time. I haven't, on a professional athlete, done a Lemaire as of yet. I'm kind of trying to figure out if that's necessary or not. And because these are high impact athletes that are going back to high impact sports. So I haven't gone down that road yet. Certainly it may be in the future. And then, you asked another question about graft types and what we use for our ACLs these days, and still using a lot of bone, patellar tendon bone. I abandoned the hamstring, and I'm curious to actually hear what you have to say, because there's been some controversy over the internet world about the quad, and I've done a lot more quads recently in my practice. For those smaller patients, obviously growth plates that are open, but I've been very impressed with quad grafts and thickness and the amount of collagen that you're getting in the tunnel. And I'm curious from a PT perspective if you've seen any issues with the quad grafts that are coming through, and other you guys as well.
I don't really have a whole lot different. I'm pretty similar to Dr. Kaplan. I'm pretty BTB heavy, and I think the lateral sided procedures are really interesting. I can't wait to see. I think we need a lot more data. I don't always tend to do it in the primary setting. I think the stability studies and the ones that are looking at soft tissue grafts with LET procedures, I think have a lot of really good data behind them. But I think we need more head-to-head comparisons, BTB, which in general, I think most people are using for higher level athletes with a little bit of a reduced risk of re-tear. I think comparing those to the soft tissue grafts plus LET are going to be interesting as more data comes out. I haven't done it in a primary. I think we don't know. One of the concerns of the LET, I think it's really great, and I think it's really powerful, and I think it can hopefully help with occurrence rates. But one of the concerns that we won't really know until 20, 30 years out is the theoretical risk of overconstraint of the lateral compartment. Will that lead to advanced changes of OA in the lateral compartment over time? And I think we just won't know that data until we've been doing this for enough. We've been doing the LET for a long enough track record to tell. But I'm pretty similar to Dr. Kaplan. I do it a lot in the revision setting for sure. And anyone with a 3+ or explosive pivot, anyone that has connective tissue disorder like Ehlers-Danlos, or they're just hyperligamentically lax with a really increased or heightened Baden index, or like really loose females, I really do consider using it in the primary setting, but definitely revision is where I use it the most.
First, to kind of go back to the rehab side, it's interesting because I think it does vary slightly based on how the surgeon is harvesting their quad graft. I find a lot of patients really like the horizontal incision. It seems to heal better for whatever reason cosmetically. And for some reason, a lot of the athletes we work with like when their scars heal and disappear and they don't have to think about it anymore. The vertical ones, for whatever reason, just seem to stick around a little bit more. And I'm not sure why that is. It could have just been kind of like, our limited population that we see here. But I certainly see a lot of patients gravitating towards that horizontal incision as the one that they prefer to see, so to speak. I do think that the AMI effect that we see post-operatively is much stronger in the quad graft than the other grafts. I think the hamstring graft is probably the quickest and easiest for us to get back as far as quad strength goes, just because we don't disrupt the extensor mechanism at all. However, I will say, in particular, with the return to run process, we have to spend a lot more time looking at, assessing, and addressing rotation of the knee, because typically when they pull a hamstring graft, we're pulling from hamstring muscles that internally rotate the knee. So understanding that there might be a slight difference in how the knee functions through rotation, and understanding that rotational control is really important for a knee that we had a ACL reconstruction on. I think a little bit of additional attention there is essential. I would say that compared to the BTB graft, I see a lot less long-term pain and long-term discomfort in the quad graft. And I obviously like that a lot because it's a lot easier to load something that doesn't hurt. So I see a lot less pain. I do see some less decreased apprehension there as well, just because there's not that stereotypical anterior knee pain when we push the knee forward or load onto the knee heavy. But, with that in mind, I think that the majority of our rehab approaches have advanced enough where, even if someone does come in following a BTB and they have that anterior knee pain kind of presentation, we've gotten creative in the ways that we can still put load through the structure, within their tolerance, whether that's the incorporation of BFR or NMES modalities and that sort of thing. And the other piece I'll add to that as well is even just our understanding of how to manage that anterior knee pain from a tendon loading standpoint and exercise and other variables that can impact tendon health, I think has evolved as well. So I certainly see the anterior knee pain kind of pop about, but it doesn't seem to last nearly as long as I think it did when I first started rehabbing athletes that way. I think that for the most part now we're able to get them calmed down within a period of 4 to 6 weeks after loading, whereas originally it was something that could persist for months that way. And I think a lot of that traces back to BFR, stim, isometric loading, a lot of tendon loading, and understanding the effect that, low and slow burn, has on that tendinous kind of structure that way. And Dr. Kane, the other point that you brought up that was really interesting to me was that concept of we don't know where the lateral articular ligament procedures will be in 20 to 30 years, or the effect that might have on the lateral compartment of the knee. And it's interesting to me because this almost feels like a bit of a black box to me, because on one hand, we certainly don't want to do something that could increase it. But on the other hand, if they re-tear and need a second surgery or a third surgery, possibly, I would imagine that that would also accelerate arthritic formations quite significantly as well. So then it becomes a conversation of, do we do the additional procedure to try and add additional stability from the start, or do we kind of forego it because we don't know the long-term implications of it in 30 to 40 years? Because I certainly think that from the research I've seen, it does a phenomenal job at adding stability to the knee. And there's a huge case to be had for a stronger, more stable knee, especially with rotation. It's just a matter of we can't always predict who's going to re-tear. So understanding that, I think there's a good time and place for it. On one hand, again, it may increase stuff on the outside compartment of the knee, but if they re-tear, I also think that's going to open up a whole new can of worms that we'll have to deal with. That's also going to accelerate arthritic formation and other changes within the joint structure itself.
Yeah, Dan, I would just say, I think there's different philosophies about graft choice, about concomitant procedure. One school of thought is trying to preserve potential future graft options. And the second school of thought, the one that I admittedly tend to subscribe to most, is to try to do everything the first time to prevent needing to go back a second time or deal with any further injury. And I think we would all admit that there's no guarantee that further injury will not occur. There are some steps that we can certainly take to try to mitigate that risk as much as possible. And in my hands, I counsel patients that I think, based on everything that we know today, the ability to have success long term is less related to whether we use your quad or your hamstring or your patellar tendon, and more related to performing a procedure on the lateral side of your knee. I think the clinical studies all bear that out. and show significant reductions in recurrence rate of both graft tear and further injury to the meniscus, which is just as relevant in the long term in my mind. So that's how I typically try to counsel patients. But I do understand that there are different philosophies about how to make decisions regarding graft choice and concomitant procedures.
Is that independent of what type of meniscus repair is performed, whether it's inside out, all inside, regardless of what meniscus repair? If we do the extra-articular ligament and add additional stability, it's less likely to be re-injured?
For me, it doesn't really affect the way I repair most of my menisci, at least, medial meniscus. I'll do an inside out, or not inside out, an all inside, excuse me. And I'll use an all suture anchor type device to repair my medial meniscus. With my lateral meniscus, I'm a bigger fan, and a lot of the meniscus we see laterally will have a little cuff of tissue still, or the capsule still. So I'll try to do not going all the way through with anchors to the outside. I'll try to use a device like the Arthrex meniscus fast pass, where I'll try to just repair it to that cuff of tissue, because the lateral meniscus obviously is a lot more mobile than the medial meniscus. So I always worry about really, doing those all inside anchors and getting too much compression of that meniscus against the tissue in the back. So to me, that doesn't really change the way I do meniscus repairs. I do those two separately, just based on the mobility of the lateral meniscus versus the medial meniscus. Started playing with doing more of an inside out repair, but a lot of these devices that we use now make things very simple to use and very effective in terms of repair.
I mean, I'm primarily an inside out repair technique, and that's just because that's what I'm most comfortable with and what I feel in my hands I am best at. But I would say that some of these lateral meniscal tears, these tears, these oblique radial tears that are adjacent to the posterior root insertion, heal very well with simple side-to-side repairs. And don't really require any type of device other than suture to be able to get them reapproximated. They have an amazing propensity to be able to heal. But for the other tears, particularly the lateral tears, where if we're doing a lateral augmentation procedure, we're already making an incision laterally. So that inside out repair can be done through the same incision. For those of us that do inside out repairs, obviously on the medial side, it requires separate incision and separate dissection. But I think, it really is dependent on what you're most comfortable with and what you feel like you can do the best job of securing that meniscus. And whether that is one technique or another, I don't think is as important as really just technically doing a good job of stabilizing that meniscal tear.
As we have discussed so far, there's a lot that goes into this conversation of ACL surgery and meniscus repair as well, and even other structures that could be also involved that way. And I guess it's one of those things that can certainly seem overwhelming to an athlete who comes into your office at first. It's usually a lot to take in, a lot of information, a lot of considerations, choices to make, and obviously at a time when emotions are typically running a little bit high. So how do you go about approaching that kind of day one conversation, and what kind of things do you really think is essential for the athlete to know about the ACL injury, what the surgery is going to entail, and what the rehab process is going to look like as well?
I think the shock value of learning for an athlete that they tore their ACL, if they haven't been given the diagnosis already, is it's pretty striking. We've all been there. The emotions run high. The athlete has a million things going through their mind, and I think psychologically, going through an ACL and coming back from an ACL is just as difficult, if not more difficult, than the physical aspects of actually getting their strength and their motion and their strength back. And so, for me, I think that first conversation, I try to just instill them and their parents. A lot of times it's younger people, that this is, something that is not threatening to their careers, and if they're going to want to play and that they're going to be able to do so. And to me, it's more about calming their fears down rather than throwing too much information at them at once, like graft choice and meniscus and cartilage, because it's just, that they're not hearing a lot of what you're saying, just based on the fact that they're trying to digest that their careers have taken somewhat of a alternate path for a little bit. So a lot of it for me is the psychological part of just instilling in them the basics of what it is, what's torn, we're going to get you back to be able to play. And then, the next visit for me is the one where, we obviously get them to rehab and prehab and get their motion going. And the next visit is more of a technical discussion of what this entails and understanding through the models and the pictures and whatnot of what we're doing. So that's kind of the way I approach things, unless someone's come in with the diagnosis already and they've already had time to digest. But a lot of times you're seeing the patient for the first time and giving them a diagnosis, and that psychological part's very difficult.
Yeah, I completely agree. I think that first time, I don't think they hear anything past my ACL is torn. So it's just, I do the same thing. I frequently, in like a few days or a week, I'm gonna go home, digest it. I'll talk to the parents and bring them back in because, yeah, they don't hear anything. You could say quad, you could say we're going to take a biceps tendon from their arm and put it in. They have no idea. So, yeah, I think the psychological component, like you said, is huge. And I think just giving them time to digest and work through it and then come back in. But yeah, like you said, if they've already come in with the diagnosis or they know it's torn, that's different. I think they've had time to kind of think through it a little bit. But then I'll get a little bit more technical. But I think the discussion's ultimately the same. I let them choose. I kind of try to gently shy them away from hamstring unless there's some real weird reason they want that. But I think that's kind of, I don't know, falling out of favor a little bit. But quad or BTB, and I let them pick. I really, even in older patients too, and I know we're not really talking about that much on here, but allograft, even in my older athletes, I really try to shy away from too, unless they're really just like a stay-at-home mom and don't really have a lot of demands. Even in 40, 50-year-olds, I kind of tend a little bit more towards autograft, to be honest, and maybe I'm wrong in thinking that way. But I just try to give them all the data and let them decide and then go with what they want.
Wait, is 40 or 50-year-old, is that old?
Right. Again, I give them the data. 40 from the Mars data or the moon cohort is the roughly equivalent retail rate. So I'm not saying old, but yeah.
My age for autograph just continues to age with me.
Right.
Absolutely. Yeah, I think the thing that makes the ACL injury unique, though, is that when a patient is given a diagnosis of an ACL injury, they instantly know the implications of that. They know what that means. Whereas if they tear their meniscus or they have another injury, they really don't know what that means to their future because so many of these young athletes have friends and teammates who've been through it. They know what that means. And as Kevin alluded to, they sort of work their way through the stages of grief. They're angry early on, and I tell them that they have every right to be angry that this happened to them. But ultimately, they're going to come to acceptance and they're ultimately going to succeed in the long run. But at the same time, I try not to ever mislead them and suggest that this is a good thing for your athletic career. It clearly is not. But it is something from which they can recover and they can return to a very active lifestyle and do the types of things that they want to do. But it's going to require a lot of hard work and dedication on their part. And I'm constantly amazed at how many prior patients from the past, ultimately it shapes their life in some positive way, where ultimately they choose a career in healthcare. They become a physical therapist, a nurse, a doctor. In some way, they make it they sort of turn it into a positive for them, which is really an amazing testament to the human spirit, quite honestly. But it's fine early on to be angry and to be upset, and that's something that you just have to work through. But I do think when they have friends and they have teammates who've been through it, they have a sense of a support group to some extent that they can rely on, which helps. Whereas with many other injuries, I don't feel like it's the same.
I agree with that 100%. And it's interesting because I think that support group might be one of the biggest predictors in success that I see following ACL rehab. So, obviously physical therapy is important. Well, it's important, but does the athlete get there? Do they get there once a week or do they get there 3 days a week? Are they there for a full 9 to 12 months or are they there 1 to 2 months? Are they there and they're constantly being motivated and supported by their friends and their family and they're constantly on them like, hey, have you been doing your exercises? Have you been doing this? Have you been doing that? Or are they just kind of going through the motions alone? And I've seen individuals have success alone, but I've seen a lot more individuals have success when they have that support group around them as well. And obviously, I don't think every physical therapy facility is created equal for the ACL, and I might be a little bit biased on that, but I think it's really, really important to have a thorough understanding of what goes into the injury, what occurs from a surgical standpoint, and what the end goal looks like for the athlete. What are they trying to get back to, and how can we kind of bridge those gaps and build the steps and progressions that it takes to get there? And on top of that, how can we kind of bring everyone together and make it a more collaborative rehab effort where we're actually communicating with their surgeon regularly, we're communicating with the patient and their family regularly, and so on that way? So what kind of things do you all look for from a rehab provider standpoint, or what kind of characteristics or traits do you see amongst the rehab providers that you're continuously sending athletes to that way? What kind of makes someone stand out as someone who's going to succeed in getting their athlete back to where they want to be after a significant injury like the ACL?
I think, one of the things that I look for is just it's the hands-on, being able to do things like get extension in the knee right away. I think a lot of times, if you get therapists that are somewhat nervous about working and putting their hands on and getting the knee straight and being able to, because inevitably the ACL, if done right and put in the right spot, is going to heal. And as we all know, a lot of it has to do with muscle tone, ability to get the quad activated, getting the strength back to be able to do the plyometric work in the end. And I think that's what makes the difference between someone getting back at 7 months versus 11 months. And so I think understanding the anatomy of how the ACL is put in. I'm always truly enjoy when a therapist comes into the operating room to kind of see how we do it. How do we tension it at the end? It's in full extension, and safe, and pushing that leg into extension is not going to hurt anything, even though the patient's tight. So, I think those kind of early milestones to me are somewhat of the most crucial periods of time. And when patients come back and if they're not fully extended at 2 weeks, I mean, that's, to me, I really harp on that. And so those are the kind of therapists that I love, the ones that want to see how it's done, and then get their hands on early. And those patients tend to do the best, at least in my hands.
Yeah, I agree. You can usually tell at that 2-week visit when they come back, like if the therapy's kind of going good or not. Like, can they get their knee straight? Can they do a straight leg raise? I hate hearing when someone will come in like, oh yeah, they just told me to go in the corner and do 10 ankle pumps and fire my quad. Like I hate the non-hands-on approach, and it just drives me nuts because you can do the exact same procedure and their rehab and outcome can totally make or break, their success long term.
Just to echo those sentiments too, I mean, I tell patients all the time beforehand that the only thing that's relevant afterwards is that you get your knee straight within the first week, particularly with a patellar tendon graft. If you have a significant deficit of extension at a week out from a patellar tendon graft, chances are you're not getting that back without going back to the operating room. I do feel like the soft tissue grafts have a little bit more time to get that, but it's clearly important to get extension back as early as possible. There's something about our psyche that makes us focus on success as being dictated by flexion, which obviously we all know in terms of outcome is not important for the first couple of weeks, but the ability to really focus on extension. I also tell people in terms of looking for the right place to do their physical therapy after their ACL reconstruction. If they're sitting down in the waiting room somewhere and the patients to the left and right of them have had their knees and shoulder replaced, you're in the wrong place.
Yep.
Or that the other thing I always tell them is that if you should be at a place that looks like a gym more than it does a doctor's office. So if they don't have the kinds of facilities to allow you to run and twist and pivot and be an athlete, you're going to have a lot of limitations as you move forward with your rehab. And I think that's actually pretty good. That's a pretty good marker of the places that we all feel probably do a better job of rehabbing these injuries, and as Kevin said, getting these people back sooner. So I think that's reasonable advice to give to people, but clearly there are some places that are better suited in rehabilitating certain injuries than others.
You brought up the extension piece a number of times there, and it's becoming more and more accepted that it's important, but why is it so crucial to get that extension back? And why is it that extension range of motion is such a ticking time bomb for us? And if we don't get it back within 2 to 4 weeks, we pretty much never get it back without a second surgery.
It's a good question, Dan. I mean, in my mind anyways, the way that I think about that is in particular with patellar tendon grafts, it is obviously a big insult to the extensor mechanism. When we do arthroscopy on these patients afterwards who've lost extension, their fibrosis is through the anterior interval. It's right next to basically where we took the graft out. So I think the amount of early inflammation and fibrosis that occurs in that location makes it even more important in those patients that they get their extension back right away. That's the way I think about it. And even in patients with hamstring grafts or any other type of graft, they can still form fibrosis in that same interval, even though we really haven't done anything to violate the patellar tendon in that interval. So I think there's probably, I'm thinking about it a little bit too simplistically, but that's the way in my mind anyways, that it makes the most sense.
And
Yeah.
I always tell my patients, in the preoperative area, I have my patients bend their knee up to about 60 degrees or so, and say, try to give me a good quad contraction. I mean, it's an exaggeration, and then I have them straighten their leg all the way and say, now give me a good quad contraction, and I show them the difference. You really, it's extremely difficult to really engage hard, get a hard engagement on the muscle if your leg is bent. And obviously it's a big exaggeration. We're maybe talking 10 to 15 degrees, but that 10 degrees, if you have that inability to get it straight, makes a huge difference on getting that quad back. All these patients have had ACL tears, which is an insult already to the quad mechanism. We see muscle atrophy right away. And then we do surgery on them, whether it's 3 or 4 weeks later, and add injury to insult to injury in terms of the quad. And so we spend so much time trying to get that quad back. But if they can't engage it in the beginning, you're setting yourself back. And for an athlete, every month you set them back is crucial to them. So that's why I harp.
I agree, and I think it's a domino effect too. I mean, if they can't get their leg fully straight, the minute you let them ambulate without crutches, I think they're going to be limping. It's just a really hard habit to break. They really need to get full extension to be able to, again, domino, walk first, then run. And if they can't get it fully straight, I think they're going to be behind the 8 ball from the get-go.
There's a lot of different factors that I've seen impact someone's ability to get extension and quad back after surgery. And I've noticed a difficult time, or a more difficult time, I should say, in individuals who have a longer tourniquet time. And maybe that's just a correlation, or maybe there's actually something to this concept of, 90-minute tourniquet time being more difficult to bring a quad back. And the other issue I've seen a lot, unfortunately, is sometimes, for whatever reason, on post-op day one, they're coming in and the brace is locked, but there's a slight bend in their knee in the locked brace. And I really would like to see a perfectly straight knee, or as straight as possible, in that locked brace, as opposed to locking them in a slight 10-degree flexed position, because it's a huge battle to try and get back from that bent position, as you mentioned, to a fully straight position. I'm curious, do you guys have any different approaches, whether that's decreased invasiveness from a surgical standpoint, more arthroscopy, or a different kind of tendon harvest technique, or a difference to how you kind of go about managing the tourniquet with the athletes that you work with from a surgical standpoint that you've found brings their quad back quicker afterwards?
I think a couple of points with the quad and with knee extension. I mean, that starts preoperatively, so it's why it's important for someone to regain full terminal extension prior to surgery. I'm also a firm believer that you have to have someone lie prone with their knee at the edge of the table to really get an accurate assessment of their knee extension. So we do a lot beforehand to try to educate patients about the fact that, as you said, you cannot get the brace is not keeping your knees straight. You're lacking extension. So take the brace off. I try to get them to lie prone within the first day afterwards to let gravity try to bring their knee into more terminal extension when they have a very painful quad contraction and can't do it on their own. And then just try to make sure that in therapy that they're really focused on knee extension as the most important thing early on. The question of the tourniquet, I think, is a very interesting question. I only use the tourniquet to harvest the graft. So on average, it will be up 12 to 15 minutes. I don't use a tourniquet otherwise. And I think we've had a lot of interesting conversations about what, if any, difference that makes in terms of rehab. I'd be interested to hear what Patrick and Kevin have to say about that. But it only makes inherent sense to me that it has some impact on the ability to be able to fire your quad afterwards.
I'm the same. I do the same thing. I only put the tourniquet up for the graft harvest, and then it's down for the rest of the case.
I'm the oddball then. I use it for the whole case. I don't like to put the pump pressure up too high, so I have it on for the entire case. But it's I don't know, that old saying, just don't rush, but work quickly. And I try not to have 90-minute tourniquet times for an ACL with meniscal work. It's kind of long, so we'll put it down to close. But I mean, I'm sure it does have an effect, but I just try to get on it, like you both said, with preoperative education. It feels better for patients to put a pillow under their knee or have the brace locked in 10 degrees. And I just try to really harp on them. No, you can't do that. Like, I know it doesn't feel great, but just elevate your whole leg as a unit. Don't elevate from the knee only. You got to lift the foot up too and keep it fully straight. So I don't know. I'm the oddball out for the tourniquet. I use it for the whole case, but I just try to do, again, preoperative education to try to really harp on that full extension afterwards and get the quad going with PT on post-up day one.
Tourniquet side there, Dr. Dreese, Dr. Kaplan, was that something that was kind of brought about from an educational standpoint for you all, where the tourniquet was not a big thing earlier on, or has that kind of come about as an evolution to your practice that way, where initially tourniquet time was longer and now it's a shorter tourniquet time for your procedure that way?
I had guys 50-50. I mean, some guys in training used it, some guys didn't. And when I got out of fellowship, it was just kind of the way I started. And maybe it was, when I started, just felt like, all right, I can take the graft and I can take my time with the case. I'm not worried about tourniquet time. I don't know if I can't remember that far back, I guess, but no, I'm comfortable, and my anesthesiologists do a very good job at making sure, to Patrick's point, the blood pressure can be an issue, and so my anesthesiologists are fantastic at keeping the blood pressures low and towards 100 systolic, and that just really controls the blood pressure so that I don't have to worry about the pump pressure being too high, and I have not had, knock on wood, haven't had a problem with it.
The other thing that's been an interesting addition from my end that I've seen is some surgeons are now aspirating fluid at their first post-op follow-up, because obviously that effusion that becomes present in the knee can be very irritating, can cause some of the pain, but can also contribute to that quad AMI that we mentioned earlier, and it can become increasingly difficult to activate that extensor mechanism that way. So I'm interested, for the three of you, are any of you doing anything in the way of fluid aspiration early on, post-operatively that way, or is there anything else that you found really works well to manage the post-operative effusion and get that controlled quicker?
I try not to aspirate unless they have a tense effusion that really is a problem for moving their knee. I try not to aspirate them in that early post-operative period. I have just so many concerns about infection, and granted, obviously, if it's done via good technique, the risk is pretty low. But I think the most important things that I really try to counsel patients are that they need to understand early on that the primary goal in terms of motion is to get the swelling down in their knee, which means they need to remain elevated, use some kind of cryocompressive therapy, but remain elevated with ACE wraps and other forms of compression on their knee. So I think just having an understanding early on that if you can get the swelling under control in the early stages, you can tend to progress much more reliably than if you're on your feet a lot and your knee swells up. It's very hard to get back on track like that. So just trying to impress upon people the need to really focus on that.
Yeah, I agree. I rarely aspirate on the first post-op visit unless it's really large. I think that's the knee swelling or effusion. You can limit the quad maybe, but I don't really think it limits their extension at all. So I'm not that worried about it. It limits flexion if it's a really tense effusion, but that's going to go away and we're going to regain that flexion later anyway. So I agree. I don't really want to, even if it's a really low risk, even mess with the possibility of infection. And I agree. I try to just really harp on, compression and ice. And I wish I could get everybody a game ready device because they're amazing. It just isn't cost effective. And I wish I could rent them out to everybody. We send them home with a cooler device, but the game ready machines are awesome. They do the compression as well as the cryotherapy at the same time. But yeah, I don't typically aspirate unless it's unusually large.
Same with me. I don't typically aspirate for the same reasons.
That makes a lot of sense given the reasons that you outlined that way. And as you were talking, the term progression came up again, and that's come up a number of times, whether it's progression of range of motion or progression from one stage of rehab to the next and so on that way. Has there been anything that the three of you like to see as far as a progression criteria goes, or when that progression gets all the way back to the conversation around return to sport? Is there anything that you've seen hold tried and true in the literature as far as a return to sport test or functional battery, and what kind of things do you look for that way when your patients get to that stage?
I think you could probably tell us more on that, Dan, to be honest with you. But I guess I'll go first. I'm biased by my training in Vail, and we have a Vail sports test that was from Howard Head Physical Therapy, and it's a really hard test. Like, I think sometimes I'd have a hard time passing it, but it's single leg squats for 3 minutes, and it's just an objective way. I have them score greater than 17 out of 20 on that test, and they can combine it with hop test, and I try to have them have 90% quad strength compared to the contralateral side, and if they hit all those criteria, then I think they're as good as they can be to go back and minimize the risk of graft re-tear. But I don't know if that captures everything. I don't think it does. I think there probably is some better form of testing out there that maybe we just don't know about. And like I said, I think you're up with more of the latest, greatest on like force plate testing and all that kind of stuff. So I don't know. I think there's always a lot of data out there and more studies being done, but I think there's still a lot that we don't know on when are we truly ready to return these patients back physically, but also, like we mentioned before, psychologically as well. Are they ready to return to sport even from a mental state too?
I mean, I use a set of tests that kind of look at overall size of the muscle. So looking at the quad girth and try to get it, above and below the knee and within 2 centimeters. And then, I'll have the strength and conditioning test that we all know about, whether it's a single leg press, single leg squat. And then I'll have them do the functional tests, the single leg hop for distance, the single leg hop, the 3 hops. And then, the crossover hop test, things like that. And then, for my professional athletes, if there's the availability of a force plate, then I'll have them do certain goals to measure on a force plate, whether or not they've within 85% or 90% of the other side. And so I have a checklist, and it'll say left and right, and there's a column, and my physical therapist will fill that out left and right. And when the athlete comes back in, I'll look at those just to give myself some sort of, objective way to tell the athlete they're near ready. It's difficult when you tell an athlete, hey, you look pretty good. It's been, 7 months, 8 months, your quad looks okay. You're ready to go. I always found that very difficult, at least at the start of my career. And so I, over time, have just kind of developed, looked at as much literature I could find and made that list. And I use that. And then, like I said, in the professional setting, the force plate comes into play, and we have our sports scientists there as well. Because it's not just a number. We know biologically that the graft is going to peak out near that 9-month mark and still gain strength even up to 2 years. We know that, but we don't hold athletes out for 2 years. So just to have some sort of objective way to measure that, I think is still somewhat important.
I think, we've come a long way. It wasn't that long ago that the criteria was 6 months and 1 day for return to play, which now I think we all recognize was never probably a good criteria to use. So I think, we continue to learn more and more about functional testing and predicting safe return based on that. So we've made a lot of advances with respect to that. I think the other criteria that, at least for me, is important that I found is a problem is I really don't like athletes to start to return to any kind of impact activities, running, any kind of impact until their effusion is nearly completely resolved. And their motion obviously is very good, because I've just seen too many people that if you try to force them down that road into impact when they still have an effusion and are still clearly having distress within their knee, that never really ends well. So I think that's another step in there in the progression of their rehab, where it's important that they're able to achieve those things before they move forward.
Completely agree. It's interesting that you bring that up, because just personally, I just don't think it really makes sense to progress someone to more advanced activities if they still are carrying an effusion in the knee. And if they're still presenting with an effusion 3, 4, 5 months out, then it kind of becomes the question of why. Typically, I feel like that's typically resolved within the first month to 2. I very rarely see athletes who are still presenting consistently with effusion at the 3, 4, 5 month mark. And if they are, I do think we have to dig deeper on that, because that's not necessarily what I would call a normal finding. You did bring up the interesting notion, though, that at one point not that long ago, that 6-month mark was the clearance mark for a lot of individuals following ACL surgery that way. And I've still seen cases where athletes are returning to high level sport at the 7-month mark and at the 8-month mark, when in reality, I know a lot of times that 9 to 12 month is kind of the standard of return based on timeline that way. How do you kind of go about balancing that timeline versus the criterion that an athlete might need to meet in order to, obtain that return to sport clearance that way. If someone looks really, really good at 8 months, are we willing to clear them, or do we hold them out for that extra month? Or what really goes into that kind of like consideration of clearance based on timeline versus criterion? Because, to a certain extent, I know it's easy to tell athletes to wait, but at the same time, there's a lot of other factors and pressures, whether that's society or position on a team, and that's how they're, earning their living, that way, that can kind of impact this decision and just really muddy the waters of how we clear athletes to go back.
Yeah, I think that's really interesting. I think that's where life comes in. It's like a lot of factors. What sport are they going back to? Like, where are they at in their career? Is it their senior year of high school that they're trying to make it back? Is it a professional athlete? I don't know. I think there's a lot of considerations for that. I thought it was interesting. I guess ask you, Dan, and both of you, like, how do you deal with that patient that maybe is in your clinic and they look great at 8 months and like or 6 months, even that's 6 months in one day, and or do they go to other providers to get cleared, even though we know that's probably not the best. I just counsel patients on the data. I reference the UD Oslo cohort study a lot. Every month you wait from 6 months to 9 months, your risk of graft re-tear goes down by 58% per month. So I think when you frame it the right way to patients and parents, I think they get it, and they get that you're not just trying to be mean and hold them out, and you want them to get back too. But I think it also helps to have a discussion with them and like, listen, if you tear it again, you got to start this whole process all over again. And I think sometimes those statistics and like just giving them a realization of what could happen, I think helps them like cool their jets and not like be so gung-ho to get back in right at 6-7 months. But I'd be curious to hear what you guys say, how you guys tackle that too.
I frame it, from the beginning. I'd say, look, we know from our literature that, average NFL football player takes about 10 months to get back. And, we all know Adrian Peterson got back in about 7 months.
Right. That's the one that's like such a, it hurts.
Right. Right. But I say, look, he's getting therapy 7 days a week, 24 hours a day, 365. And I tell them that, that the biology of this, and I go through with them I draw a graph on the table, on the paper, as to the strength of the graft. And as you pointed out, we know that graft strength will increase. And I'll say, look, it's not out of the realm of possibility to get back a little bit sooner than, the 9 or 10 month mark, but everything has to line up. And for me, the measurables have to be there, and then we can have that discussion. But I certainly set the expectation from the beginning, once we have that discussion, that, give yourself about 10 months and we'll see where you're at after 8 months and see how far along you are. And, I've had good results with that. I mean, certainly there's some patients that'll just push and push and push. And, I kind of stand my ground and say, look at your quad, look at the strength, and I'm not going to put you at risk, and go from there.
Yeah, I agree. I mean, I think it starts with setting expectations at reasonable levels before you start. I think if you frame the discussion in that way, it helps in the months ahead, just in terms of the expectations. But just in terms of moving forward from there, I also, as Kevin said, talk to them about studies that show radiographically it takes a year or two for grafts to more completely mature and incorporate. As Patrick said, the studies that really look at how the re-injury rate drops significantly after 6 months. And I also really try to impress upon them that your best chance of having a successful outcome here is to have one operation on your knee. It's not to come back and do a second or a third, even irrelevant to the independent of the year it's going to take you to recover from a second surgery. Just in terms of the functional level that you get back to and what you're able to do, all the evidence shows that one operation has a better chance of that than the second or the third. And just try to frame the conversation in that way to give a realistic understanding of the fact that it's going to take some time. The other thing that we talk more and more about as well is the physical recovery versus the psychological recovery. And the psychological recovery is a significant part of the recovery process. And by all indications, it probably takes longer than the physical recovery. So, I think just in terms of re-injury risk and all these other factors, there's a lot that goes into preparing for return to play. And it doesn't necessarily just mean that you feel like your knee's at full strength. You have to have full confidence in your knee and psychologically feel like you're ready to return.
That's so interesting that the psychological element continues to come up, and I can't help but wonder if someone will eventually look into that a little bit more and study, almost like more of a psychological readiness assessment in the return to sport conversation as well, because you're right, we've definitely evolved in our ability to assess objective outcomes and objective measures on the athlete that way, but all of them have mostly been physical in nature and not many have been psychological in nature. So that's such an interesting point as it enters this conversation that way. And, I think the other thing that I am seeing more and more, in fact, we had a individual who had worked with a previous PT who actually returned to jujitsu 2 months after surgery, but he told me it was okay because he had his brace on. And it's interesting because I've never really seen, and maybe it's just me, I have not seen as much merit and value in the functional braces outside of that psychological effect, like you mentioned. A lot of times athletes feel more confident and more secure when they have the brace on. And if that's the case, then I'm certainly not going to be the one to tell them not to wear it. But when it comes to this concept of bracing a knee following, return to sport that way, is there a good place for it? Do we feel that braces are largely overrated, or where does that kind of fit into this whole conversation around returning to sport?
I can maybe tackle that one first. In full disclosure, I do get some consulting fees from OSER, which is a brace company, but I give the same speech. The knee bracing industry is a $6 billion industry. 70% of ACL surgeons prescribe a brace postoperatively. There is little to no data to show it does anything. The only two sports that really have been shown any improvement in risk reduction for a re-tear is downhill skiing and BMX motocross. That's it. So I prescribe it, and I have patients wear it for the first full year of return to sport. I always tell them about my brace, and going back to what we said earlier, I was one of those stories. I tore my ACL in high school, and here I am fixing ACLs. So it does have a pretty big impact, but I still have my brace in my parents' closet back home. I don't wear it anymore. I've wore it for probably 4 years post-surgery. I think it was like my security blanket. And then eventually I just kind of got more confident and weaned out of it. It just makes me sleep better at night. And I have them wear a brace for the first full year of return to sport with really no data to back it up.
I'm the same way. I prescribe it, tell them to wear it for a year. My professional athletes, after they're returning to football, I have them fitted for a custom brace, and it always hangs beautifully in their locker. Because they just don't wear it. But it makes me feel better that I know that I got them the brace to wear. But I tell most athletes, and I do, I see a lot of, Floridians aren't maybe not the best skiers. So I do get a lot of ACLs that come back from skiing, and I have them wear their brace. Same thing for the first year. Now, I put them in a post-op long brace for a little bit of time, and then get them out of that brace altogether, and try not to put the functional ACL brace on them until their quad's strong enough and they've built the strength that way, and just have them use that brace for those contact type activities.
Yeah, I think I'm the outlier here. I don't use braces in anybody. But I do think that potentially the biggest marketing success of our time may be the bracing companies convincing patients of the benefits of functional braces following ACL surgery, in the sense that, as Patrick said, the studies all pretty universally show that there's not a reduction in the risk of re-injury, but yet there's the perception amongst the public that a brace has a protective effect. I would say that the one time I do use a brace is with a collateral ligament injury. So if a patient's had a collateral ligament reconstruction or repair, I will tend to brace them more so. But from the standpoint of the ACL reconstruction alone, I don't generally prescribe those. I do tell people, look, if psychologically you would feel better with the brace on, I don't think it's going to hurt you. There's very limited evidence that suggests that it might negatively impact your performance. It's not likely to increase the risk of you re-tearing your ACL, but at the same time, the data shows that it's not likely to reduce that either. So as has already been mentioned, I do find that for those who wear it, they ultimately discard it because they feel like it makes them less athletic. They feel like it slows them down or restricts them in different ways that makes them less competitive athletically. But I don't generally prescribe it unless someone just really feels like they'd be more comfortable with it.
brought up, Dr. Kane, that, in the past you tore your ACL as well. And obviously that speaks back to where we started about the fact that this can really become something that changes someone's life, in the sense that they can tear their ACL and then in the future be the guy who's fixing ACLs on other individuals that way. So I think it's really interesting how it kind of comes full circle that way. And I'm just kind of curious more than anything, have Dr. Kaplan, Dr. Dreese, have either of you experienced an ACL tear yourself? And Dr. Kaplan or Dr. Kane, what have you kind of learned just going through that experience yourself that way that you kind of carry with you into your clinical practice now?
I'll let them answer first. I don't know if they have the same experiences or not.
Thankfully, I can say I have not, and I hope I never do. It's not something I feel I need to experience personally, but I'm sure, though, if you have experienced it, that it changes. Life is about experiences, and we're shaped by those. I have some colleagues who I know have torn their ACL, so I think if you polled the Orthopedic Surgery Society in general, there's probably a significant number who've been through that before.
Yeah, I did not tear an ACL. I broke my ankle and my in high school, and I spent a lot of time with a physical therapist. And when I went to college, that was my goal, to be a physical therapist. And my orthopedic surgeon at the time said, I'll set you up with a physical therapist, but why don't you come watch a couple knee scopes and before you go to therapy? And she took me in for a couple knee scopes, and I watched one, and I'm like, that's what I want to do. And that changed my life. So kind of, but I didn't tear my own.
Well, you're lucky. Yeah, I mean, it's been on my personal statement for medical school, residency, fellowship. It's like, but it was true though. I wasn't making it up, and it was why I'm doing what I'm doing today. It's just, I grew up in a really small town in Pennsylvania, and there's nothing. I mean, I love where I grew up, but there's not much going on. So sports was everything when I couldn't play. I mean, it's devastating, and I think it just speaks to the psychological impact these injuries have on you. So, what the guy who fixed my knee, I literally thought he could walk on water. So I'm like, I want to do what you do. So ever since then, that's been my career path. And then when I was in fellowship, I didn't tear mine, but my wife tore hers skiing. So we got the double whammy. But I don't know. I mean, you don't have to go through an ACL injury yourself to be able to relate to patients by any means. I just think it is helpful, because I always tell everybody it hurts. Like the first 24 to 48 hours, it's pretty rough, but there's a lot more that we could do now. And there's a whole separate webinar thing on pain control after ACL. But I tell everyone, listen, gut it out 24, 48 hours, and then it is like a light switch. Everybody's off pain medicine, no more narcotics. But I just think going through not just the acute surgical pain, but just the whole rehab process, it takes forever. And then I've gone through it now, both as patient and surgeon, but also spouse. It's just interesting. So I don't know. And everyone's experience is different. So that's the only thing I tell patients, I caution them at least, Dr. Internet is great, but don't look up all these like blogs, and everyone's experience is different. So you can get some data and info on the internet, but your experience is going to be different than, John's experience and Timmy's experience and Susie's experience. Everyone experiences it in their own way. But I don't know. I guess I have a greater appreciation for what they go through because I was there too. But it's rough. It's rough for the first couple of days, and it's a rough 9 months, mentally. But I always explain to them, it's not a career-ending injury. It's a season-ending injury. We're going to get you back, and you're going to come back stronger eventually.
I'm curious too, what graft did you have?
BTB. Yep.
It's funny because I know you're kind of like the BTB guy on the shore. So I just kind of, again, full circle moment there. As we were kind of talking today, I feel like we covered a lot of different points and important considerations for athletes to understand about the ACL, but also for providers and clinicians to understand as it goes into what they should be doing from a success standpoint, and also what goes into the surgical side and some of the many different approaches that we have to tackle this problem, whether it be graft options, tourniquets, and so much more that way. Is there any kind of closing thoughts or closing remarks or anything that we missed as we were chatting today?
I think we did a great job covering a lot of different topics on it. I think the important points are that we're continuing to evolve and get better, and what grafts we use. I think biologics is here, and as we talk about cartilage and things like that, we'll kind of continue to better our ability not only to stabilize a joint but preserve it in the future. So I think that's kind of the next wave in treating these cartilage injuries. But it's been a fun ride, at least for me, starting in residency and coming to practice now as we continue to evolve our practices.
In addition to biologics, is there any predictions for where we're going to be from an ACL surgeon's surgical standpoint in 10 years' time?
Well, I do think that from the biologic standpoint, that there have been some pretty significant advances in our understanding of repair and of the bridge enhanced ACL reconstitution. And clearly there are some frontiers ahead that involve more biologic understanding and potentially some different treatment options that don't involve reconstruction. Maybe one day we'll look back on reconstruction as a very primitive operation in the way in which it's done. In fact, I hope that we do. But I do think that we may be on the sort of precipice of some real significant advances in our understanding of ACL injury and potentially our ability to treat it.
I guess I have questions, Dan, for Dr. Kaplan, Dr. Dreese. Two questions. My first one, and it's a running question I ask all my friends who, have been out of fellowship, but maybe just out of fellowship or have been out for a while. What angle do you fix your LET at?
I'm 30 degrees neutral rotation.
And are you using a fiber tack like suture staple, or what are you using for fixation?
I'm using that double fiber tack, the
Yeah.
one
Yeah, I do it at about 10 to 20 degrees. And my biggest concern with those is losing extension. So I do it closer to extension. In my experience, I've been doing them now for 3 to 4 years. I have a couple hundred that I've done, and I definitely think they have a higher propensity to get stiff afterwards. I think the ALL reconstructions that I did for the first year and a half or so didn't seem to do it as much. I think the LETs tend to do it a little bit more, so I try to fix them as close to extension as possible. I also like that the knee fiber tack. I think just from a technology standpoint and trying to keep the drill hole as small as possible, It makes good sense. But for me, the thing I worry about the most is the loss of extension.
Yeah. You worry about tunnel convergence with your femoral tunnel for the ACL a little bit. And do you go up higher to recreate Kaplan's fibers? And I don't know, I feel like when you start tacking it down, where's the best spot to put it? And I feel like the most powerful thing you get is looping it under the FCL personally. But then that's also something that with the shoulder, we're doing something that's non-anatomic. It just doesn't make sense, but it's also becoming way more popular. And I get where it's helping to reduce these re-tear rates, but the whole LET, it's that's not supposed to be that way normally, but I think you get the most benefit from going underneath the FCL, which is not anatomic.
Yeah, I'm posterior proximal to the lateral epicondyle, to that origin of that lateral collateral ligament.
Yeah.
And then I flip cut my femur. So, as long as, my flip cutter is pretty level with the midline of the femur. And then when I put my anchor in, as long as I'm aiming anterior and proximal, then I don't have any tunnel convergence. And I put my camera back in my medial portal, so I'm actually looking up my femoral tunnel when I'm putting that anchor in, and I don't ever see it.
Yeah, I mean, I'm 3 millimeters proximal and posterior to you really just dissect out the lateral collateral ligament. It's very palpable. The back of the epicondyle is very reproducible. It's just in front of the gastroc tubercle. I mean, I think that spot is very reproducible. I agree. If you drop your hand and aim a little more anterior, the other thing is that knee fiber tack only requires a 2.6 millimeter drill hole, whereas all of my ALL reconstructions, I used a biotinidesa screw. So that's a 5.5 tunnel, which is a significantly increased tunnel.
Right.
So I take my graft and I'll go do my tunnels. I'll have my PA will be doing the graft.
Yeah.
While he's doing the graft, I'll dissect out the lateral compartment. I'll drill my tunnel. I've dissected my ALL, put the anchor in.
Yeah, but not tension it.
Yeah, I won't tension it until after I put the ACL in.
Gotcha.
So I'm getting everything. I'm just doing it for efficiency's sake. But that way I always look at my tunnel and I can see that my tunnel is converging. And then I do then I'll bring my ACL in, because by then my PA will be done getting the graft ready. Bring it in, fix the ACL, go back, tension it, and done.
My second question for both of you too, and you kind of talked about it with the Bayer study. Are either of you doing many ACL repairs? Not Bayer, but ACL actual repairs with swivel X.
I've done PCLs. I'm not really a believer in the ACL repair in my hands. I mean, in fact, I saw a young lady yesterday that had just had her ACL repaired in April at an outside institution and
failed.
I'm maybe in my hands, I'm not there.
did a couple of repairs a few years ago of what I thought were Sherman ones. And I think, the reality is that most of those are Sherman twos. And in young active patients, I saw early failures. So I certainly won't do it in a young patient. I think if it's an older, lower demand patient and it truly looks like a normal ligament, I might consider it, although I haven't done it in a couple of years because I
Yeah.
was so discouraged by the results that I saw in young patients. And I just don't agree with the idea that you haven't burned any bridges by failing an ACL repair. That's a long recovery. It's still an insult to the knee. It's oftentimes further meniscal damage. I mean, it's not that there's no downside to it. So in my hands anyways, I think reconstruction early in those young at risk patients makes the most sense. But I can see the argument in favor of it in an older, lower demand patient in whom you think there's a lower risk of failure. But in my hands, I just won't do it in young patients anymore.
Yeah, same. Like you said, just do one surgery right from the beginning is our best chance. But I was just curious if either of you were doing it. But yeah, I don't either.
Building off that repair point for a second, I've recently met a couple people who have told me that they're using a bracing protocol from a different country to allow the ACL to just heal itself. And they're going to go at the ACL rehab process non-surgically. Personally, just don't feel that we're there yet. Or maybe it's just the fact that we live in America and this concept of, we're going to do a bracing protocol and different things that are going to take 3 to 6 months. And then if it doesn't heal, well, then you're still going to get surgery. And now you're set back another 9 to 12. I just don't see that catching on here. But I guess I'm curious, any of you seen this like bracing approach to, healing the ACL and managing the ACL non-surgically that way? Or is that something that we still feel is very far off in the future?
I mean, I think we've been through some different iterations of that historically. There have been some good studies that for partial ACL injuries, that early bracing could potentially have some beneficial effect. I think for all of us who have seen so many intra-articular ACL injuries, it's hard to imagine how many of those injuries can heal without some kind of an intervention, some kind of intra-articular biologic or reconstructive intervention, just based on the displacement of the graft fibers from themselves that way. So just sort of empirically, it's hard for me to understand how that could potentially lead to healing, at least in a more complete injury. Maybe in a partial injury, that's something that's a possibility.
Yeah, I just think those, like you said, I think those studies are really unique to Scandinavia. I don't really feel like it's reproduced elsewhere, or definitely in this country. I agree. When you just see that ACL completely blown apart in the knee, that's just no way that's going to heal with bracing.
I agree that way. Interesting little twist that we continue to find ourselves facing that way. People who want to find you all online that way, Dr. Kane, I know you're still like MySpace generation out here, but if you have any like social media links or websites or anything like that, where can people find you at online?
I don't think I'm that old. My God. Although I don't really have much social presence, just my office website, to be honest with you, First Aid Orthopedics.
Yeah, so I have my website, that's kevinkaplanmd.com, and then at Kevin Kaplan MD on X, and then I'm Instagram as well.
I'm at MedStar Health, and then on Instagram at Sports.Dreese.
Awesome. We'll link to all of that in the description below. That way, if people didn't quite catch it, they can just click there and keep up to date with everything that you all are doing. And obviously, if they need to make an appointment, they can very easily do that through your websites as well. So we'll link to all of that in the description below. Guys, I really appreciate your time and all the insights and knowledge that you shared with us today. Thank you so much for being here.
Thanks for having us.